Hepatic system. So we're going to be talking about like our liver, a little bit about the gallbladder, spleen, and the pancreas. Okay, this all makes up our hepatic system. So here's our liver, gallbladder lives inside of there. Liver makes bile, collected in the gallbladder, which is then brought down through the common bile duct and dropped into our duodenum. Here's our pancreas, and then our spleen. So our liver, it's going to help with glucose metabolism, ammonia conversion, so breaking down like metabolic waste, protein metabolism, fat metabolism, bile formation, storage of a lot of our vitamins and iron, as well as the synthesis of our clotting factors. So when we see like liver disease, what we worry about is bleeding for these patients because they aren't able to make clotting factors, so like the rebar of our blood clots. So glucose metabolism. So when we eat carbs and when we eat sugar, it's absorbed in our small intestine and it is carried to our liver through the portal venous system. In the liver, it's converted into glycogen, okay, and stored. So we're going to store it there for when we need quick energy release. Glycogen is going to be converted into glucose through glycogenolysis. Okay, so glycogenolysis is going to break down glycogen into glucose that we can use during stages of hypoglycemia. This is also activated by when our pancreas releases glucagon. Okay, it's also going to activate this glucogenolysis. When we have an absence of glucose, so if we think about our like DKA patients, so this is going to be a gluconeogenesis, is when we're using fatty acids, proteins, and lactate to create glucose. This is when we're like using ketones, and ketones are amino acids. Vitamins, so a lot of our vitamins are converted in our liver. So vitamin A, thiamine we can see in our hepatic disorders because we're just not breaking down vitamin B appropriately. Riboflavin, which is used for some of our clotting factors. Same with pyridoxine. Vitamin C. Vitamin K is another really big one synthesized by the liver. And folic acid as well. So when we have folic acid insufficiency, we're also usually a thiamine deficiency. We're going to see some macrocytic anemia. So big red blood cells, but they're just not working appropriately. Our liver also breaks down ammonia. So ammonia is a product of metabolism from our GI tract, right? Our GI microbiome. Okay, all those little normal bacteria that live in our GI system, they create a lot of ammonia, which is broken down into urea by the liver and then excreted through the kidneys. So when we have liver dysfunction, we're not able to break down that ammonia, which is going to cause like encephalopathy, right? Ammonia is a toxic chemical that we shouldn't have in our body. So hyperammonemia. So this is when we have, again, large amounts or more amounts than normal of ammonia in our blood system. Sorry. And ammonia is neurotoxic, so it's going to increase our GABA synthesis, which is going to be a CNS depressant. So these patients, it's kind of be like they're going to act as if they are on a bunch of benzos. So super lethargic, tired, confused. We can see some irritability. Ataxia is like a little hand tremor. They might have a headache, vomiting, and it can lead to seizures, coma, and death. Normal serum ammonia level is less than 30. And then generally the higher the ammonia, the worse our symptoms are and the worse our patient is. We can assess this through serum ammonia level tests, but you can also see this encephalopathy in a head CT and an MRI. So hepatic encephalopathy can be life-threatening. Okay, this is when we're not able to detoxify our body from all of that extra ammonia. So when we have portosystemic shunting, so this is when we have can be a result of portal hypertension as well. So we're gonna have high ammonia levels due to not being able to break that ammonia down. And then it's also entering the blood at a higher rate because we just have that higher pressure system. So these patients can have all of those same symptoms of hyperammonia with our hepatic symptoms like jaundice, ascites, thrombocytopenia, and maybe a low sodium. Because we're not going to be converting aldosterone appropriately. So, hepatic encephalopathy. So first we're going to see some slurred speech, some lethargy. They might be confused like with day and night. So sleeping during the day, awake during the night, okay, poor coordination, a little bit of a hand tremor, be tripping over a lot of things, falling. Right, next we're going to have worsening drowsiness, some more disorientation, and some agitation. Alright, we might start smelling like a sweet, like fecal smell of their breath because that ammonia kind of has like that sweet smell. Third is going to be severe confusion. Okay, these guys are going to be obtunded, so we're going to be struggling to wake them up. When they are awake, they have slurred speech or they're just kind of mumbling and grumbling. And then stage 4 is coma, and we can have death. So treating hyperammonemia, so we can give some medication, we can give lactulose. So lactulose is going to work in the GI system, so it's going to trap ammonia in the stool. Our goal is like 2 to 3 soft stools a day, patient with lactulose. Most of the time this is going to be diarrhea, okay? We want to be careful with lactulose because it's also going to excrete our potassium. And we can give this with other medications like rifaximin, neomycin, and flagyl, because those are actually going to reduce the amount of bacteria in our gut that make ammonia. We want to eliminate the cause, so we want to treat that hepatic system if we can. If they have some sort of bacterial infection going on in their GI system, like or a gastritis or something, we want to treat that. And then they might need just some more treatment for their hepatic dysfunction, like our vitamins. I had a little patient once. He was homeless, which sucked. History of alcohol abuse, but he'd been sober for years. Wasn't able to get on the liver transplant list because he was homeless. And he would come in pretty frequently with this hyperammonia because he wasn't able to take his lactulose because he didn't have access to a bathroom during the day. So it kind of sucked. Super nice guy. But again, having to go to the bathroom all the time and not having access to it is he wasn't able to take his lactulose. Okay, so our patients who come in with hepatic encephalopathy, frequent neurochecks, right, at least every 4 hours, make sure our treatments are working. Daily weights to see if we're retaining any fluid. So accurate eyes and nose. We're going to be watching those serum ammonia levels. Sometimes if we know that they're already high, so we check it, it's high, we'll wait a few days before we check it again, or if we have like a drastic symptom change. And then we also want to maybe do some benzoantagonists. So our reversal, right, flumazenil, kind of bind to those benzocytes in our brain so the ammonia can't. Encouraging pulmonary function, managing that airway, right, especially if they're in that stage 3 and 4, they might not be able to manage their airway on their own, as well as providing education, right, like you have to take your lactulose, it's supposed to give you diarrhea, it's normal, stuff like that. Okay. So next we're going to talk about portal hypertension. So our portal venous system. So it's venous, right? And it includes our portal vein, which goes into our liver, and then it's also going to spread into our upper stomach and our esophagus, our spleen, and our kidneys. So when we have cirrhosis, when we have inflammation of the liver, we're going to have a backup of blood flow into our portal vein, right? It can't get through this big swollen liver, which is then going to back up blood into our esophagus, where we get esophageal varices, into our spleen, so we will have splenomegaly, and it can even back up into our renal system a little bit, and we can have hepatic renal system. This portal hypertension is also what causes ascites, because we have this buildup of fluids, we have hypertension in our portal veins. It's going to cause third spacing in this area, so that's why these patients have that buildup of fluid in their abdominal cavity. Come on. So, it's a result of cirrhosis or inflammation of the liver. So cirrhosis or even like a hepatitis, like a Hep B, Hep A, Hep C can cause portal hypertension. And again, going to increase the venous pressure through all of those areas and causing the enlargement of the veins. So this is again where we get like our esophageal varices. We can see like the little spider veins on the skin of the abdomen. And then we can even see like hemorrhoids in the rectum and the anus. So it's going to cause ascites because we have that increased capillary pressure, and so we're going to have some third spacing, and then vasodilation of that's splanchnic circulation. So that just includes again the same portal system. It's going to change our aldosterone metabolism. So when we have decreased liver function, we're going to have increased sodium and water retention because we're not going to be breaking down aldosterone appropriately. So we're going to have increased sodium and water retention, which is going to result in increased fluid volume, which is going to worsen our portal hypertension. We're going to have decreased albumin synthesis because our liver helps make a lot of the proteins that we need for albumin, which is just going to worsen our ability to retain that fluid within our vascular system, right? It's going to allow for more third spacing and more edema in our abdomen. And then we're just going to have increased fluid in that peritoneal space. So a lot of these patients will put them on like a spironolactone to help get rid of that sodium and water. And then sometimes we will give them albumin as well to kind of pull fluid back into their vascular system so we can either diurese it out, or we'll give them albumin before we do a paracentesis, so before we go in and drain that ascites, because if we drain it, we can have like a rebound where it just refills. So if we give albumin, those big protein molecules can kind of hold on to the fluid, keep it in our vascular system where it's supposed to be and not in our abdomen. And again, here's some more of these assessment findings, right? We've seen patients with ascites. They've got the distended abdomen, those little spider veins on their belly. Spider angioma is what they're called. So they look like varicose veins, but they're on the abdomen. They might be jaundiced. They might be a little yellow. When we do our assessment, right, so if they've got bowel areas that's full of air, we'll hear tympany, so we'll hear like a drum. And then areas where there's a lot of fluids, where there's a lot of that ascites, it'll be really dull. And then this palmar erythema is when we see like a palmar, like a red rash on the palms of their hands or the bottom of their feet. And that's just related again to that portal hypertension and that liver dysfunction. Treatments for ascites, so we'll give them aldactone. So we can give them a potassium-sparing diuretic as well as Lasix, right, to remove some of the extra fluid. Low sodium diet, a fluid restriction usually. And then we can do a paracentesis where we go in and we just drain that fluid. Sometimes patients who have like cirrhosis or hepatitis C or even like liver cancer, they'll have a port in place and they just come in and we just drain their abdomen, and then they go along their little merry day. Or we can do a TIPS procedure. So a TIPS procedure is actually a stent that they place in the hepatic vein to allow for more drainage, so blood doesn't get backed up as well, or as much. So coagulopathy in liver disease. Again, we'll see this a lot, especially like in our acute patients. So if we think back, right, they've got your liver is so important for making your clotting factors. And your spleen is important. It's going to store all of your extra platelets. Okay. When we have that splenomegaly, it's going to kind of break down those extra platelets, right? Because we're going to have inflammation. That inflammation is just going to alter our platelet shapes. And if they're altered in shape, they're not able to function as well. And then our liver is one of like our sole organs that make our clotting factors. So we're going to have an impaired synthesis of our thrombopoietin, which is used to stimulate our bone marrows to make more clotting factors. We see thrombocytopenia in over 3/4 of our renal patients. We can also see bone marrow suppression right from antivirals for a hepatitis. Alcohol can cause bone marrow suppression, as well as a folic acid deficiency, which is related a lot to let me go. Your liver cells are also responsible for making all of our coagulation factors, for fibrin, right? And fibrin again is like the rebar of our blood clots. So, esophageal varices. So we see these in 30% of patients with cirrhosis. They have a 10 to 40% mortality rate if they start bleeding. Okay, significant source of bleeding in cirrhosis. The result of portal hypertension causes the varices, and then we see this bleeding because we have coagulopathies. So here's what they look like. So they're protruding, enlarged, engorged veins up in our esophagus. And so if we think about like when we eat food, right? Food comes down our esophagus, it's not necessarily soft, and it can tear these open. Gastric acid from our stomach can come up and cause these to break down more and erode and cause bleeding. Same with like consuming alcohol, right? Alcohol's pretty rough on our skin, and it can also break down the lining of these esophageal varices and cause them to be bleeding. So assessments for these patients, we can see hematoemesis or melena. So they can be vomiting blood, they can be vomiting coffee ground emesis, or we can see dark tarry stools. In esophageal varices, it's almost going to be the dark tarry stools because we're bleeding in our upper GI system, and by the time it comes out in our stool, it is kind of coagulated. We can see it on endoscopy. All right. These patients might also have some splenomegaly. They might have some hepatomegaly as well, so some enlarged liver, as well as ascites. And then they're going to have symptoms of bleeding. So cool, clammy skin, hypotension, anemia, tachycardia. They might have pale skin, right? Pale mucous membranes. So this is a medical emergency, right? We need to stop the bleed. We can stop the bleed with a Blakemore balloon. This is an actual just like balloon that goes down your patient's esophagus, and we blow it up until we get hemostasis. These can only be in for about 24 hours before we actually have to go in there and do like a more permanent fix. Some of our medications we can do, so we can do octreotide. So octreotide is an esophageal vasoconstrictor. So it's going to constrict down the blood system of our like portal system, which can actually kind of tamponade off those veins. We'll give them protonics to decrease the amount of gastric acid, so that's not causing more corrosion. Vasopressin, so unless, again, contraindicated in patients with coronary artery disease, but vasopressin is going to, again, help kind of vasoconstrict, right? It's going to help with any hypotension as well as kind of tamponade off those veins. And then we can also give them beta blockers, because sometimes if we like vasodilate, we can prevent those varices from forming. We're not going to give a beta blocker if they're actively bleeding. And then endoscopic intervention as well. So these patients are going to need to go in and we're going to need to surgically clip or cauterize those varices. We'll also want to treat their symptoms, right? So if they're having symptoms of hypotension or hypovolemia, we want to replace volume. We want to replace bleeding products if we need to. So our hepatic assessment, right? So we want to look at our LFTs, our liver function tests. So we have an ALT, AST, and our ALK phos. Our ALT and our AST, these are going to be our hepatitis, right? These are elevated when we have toxins, viral hepatitis. Our ALK phos can be elevated as well, but this usually goes up when we have elevated bilirubin, which can be from like our gallbladder. So cholecystitis can cause an elevated ALK phos. Monitor our ammonia levels, check our albumin, right? There might be hypoalbuminemia. So we're going to have low albumin, low protein. They might have a high bilirubin because we are breaking down red blood cells inappropriately, storing red blood cells inappropriately. And then our coags, right, have thrombocytopenia, so we might have low platelet count, as well as an elevated PT, an elevated INR, an elevated PTT, so high bleeding times, meaning it's taking a long time to clot, and then low clotting factors, like our platelets and our fibrinogen. Jaundice, right? Jaundice is going to be just a result of increased bilirubin, so it's going to cause the sclera of our eyes to turn yellow and our skin to turn yellow. We'll have ascites, so that big edematous or distended abdomen. Hepatomegaly, so a large liver. Maybe some muscle atrophy, because we're going to be metabolizing proteins inappropriately. We'll see petechiae or ecchymotic area. So petechiae are those little tiny blood vessels that have burst, so we'll see like little red spots all over. Or ecchymotic areas, it's going to be like our bruising. So these patients bruise really easily, right? They don't have any clotting factors. They're going to bump themselves wrong and be bruised. We can see a general tremor, so some ataxia. And then those spider veins again, especially on their belly. So cirrhosis is a chronic disease. Okay, most cirrhosis is caused by like hepatitis B, Hep C, as well as like our fatty liver disease from dyslipidemia or alcohol abuse. So again, see a lot with alcoholics. And then also this post-necrotic, so this is just a result of a hepatitis infection. We can also see cirrhosis from biliary obstruction or infection, so we can have cirrhosis that's from our gallbladder, right? Gallbladder disease or a block in that common bile duct can cause cirrhosis. So we've compensated and uncompensated. So compensated is just going to be, even though we have inflammation of our liver, it's still functioning appropriately. All right, they're going to have some vague symptoms. They might have some spider veins. They might have some splenomegaly. Maybe we see that rash. Maybe we see an enlarged liver. But for the most part, they're doing okay. Uncompensated, these are going to be our pretty sick patients, right? They're jaundiced. They're hypotensive. They are constantly having nosebleeds because they're having that coagulopathy. Weakness, weight loss, and then mild fevers, especially at night, and that's a lot related to like hepatitis. Management of cirrhosis, so we're going to want to be doing potassium sparing diuretics. Colchicine can actually help just reduce inflammation. They'll be on ACE inhibitors to prevent that portal hypertension. They're going to be on statins, so our liver doesn't have to work as hard in breaking down fats and proteins. Milk thistle you can give for jaundice. It's just like an over-the-counter little supplemental herbal thing. As nurses, when we have these patients and they come in with worsening cirrhosis, we're going to want to decrease that metabolic demand, right? This is part of your metabolism is your liver and your pancreas. We want to make sure that they're not working as hard. So we're going to promote rest, improve nutrition, high protein, high vitamins, low salt diet. Reduce our risk of injury, right? These are fall risk patients because they don't have the ability to clot as well. Okay, so we don't want them to be juggling chainsaws or anything crazy. Daily weights to monitor our fluid status, see if we're having a weight gain or a weight loss. Hepatic failure. So this is also known as like a liver shock. So this is when we have a sudden and severe liver dysfunction. Generally, it can be within 8 weeks of our first symptoms of jaundice, or we can have this in patients who are super hypotensive, they're in hypovolemic shock, they have cardiogenic shock, they have a distributive shock, right? Any shocky patient can also result in liver shock. So again, our acute, like 8 to 28 days, and it can last up to 72 days. We can see this with viral hepatitis or medication toxicity. So patients who have had like a Tylenol overdose, and then our chemical metabolic disturbances as well. So metabolic disturbances is going to be like a super acidic patient, or our patients who again hypotensive, hypovolemic. Okay, when we have liver shock, we're going to see an increase in our LFTs, our liver function tests. These patients will be jaundice. Okay, they're going to have coagulation defects. They might have some renal disease as a result of this. Electrolyte imbalances, hypoglycemia, and encephalopathy. One of the first things that we'll see if our patient's starting to have some liver dysfunction is they'll be hypoglycemic first thing in the morning. Okay, that Somalia effect. So they might be hyperglycemic at night, and then our body's going to try to compensate by giving them a lot of insulin, but we're not able to have that glycogenesis, that glycogenesis, which is making us we're continuing to be hypoglycemic, right? Our liver isn't able to function to make that glucose and release those extra reserves, causing hypoglycemia. An elevated ammonia is going to result in that encephalopathy. Okay, then we worry about our coags in these patients. They'll probably also, we talked about high ammonia. So treatment ICU care, so some antidotes if it's some sort of toxin. Okay, so we can give acetylcysteine or N-acetylcysteine for an acetaminophen antidote. So Tylenol overdose, we give this acetylcysteine. We can also give acetylcysteine if they've had like an unknown toxic ingestion, right? Because this is just kind of a liver protectant. It's a antioxidant for our hepatocytes. And then we can give penicillin for mushroom poisoning. So when the tourists are eating whatever they find in Glacier, give them some penicillin. We might have to do some plasmapheresis. So plasmapheresis is when we remove the patient's plasma and then we replace it with albumin. Okay, because this plasma is going to contain a lot of our toxins and our ammonia. They can have a bioartificial liver. So it would be like hemodialysis, but just for what our liver metabolizes. We don't do that in Great Falls. They might have to be on some intracranial pressure monitoring, especially if they have a really high ammonia level, are super encephalopic, and then eventually might just need a liver transplant. So let's talk about alcohol withdrawals. So there's two withdrawals that will actually kill you. So it's benzos and alcohol. The rest make you feel like you're dying, but they're not actually going to kill you. So alcohol is a depressant, right? And so when we are no longer consuming it, all of those little neurotransmitters are going to be extra excitable, which is going to result in a risk of seizures and coma. Okay, so all of our GABA sites are now being excited. Some nursing questions, right? Have you ever gone through withdrawal before? How did it go? Did you have a seizure? All right. Did you go into DTs? We'll talk what DTs are. So delirium tremens. Have you ever done this before? A lot of times if it's their first time withdrawing, we don't know. And it's really dangerous. And if they've gone into DTs before, they'll probably go into them again. How much do you drink every day? And then when was your last drink? Symptoms usually occur within the first few hours, but it can take a day or two before we start seeing symptoms of withdrawal. Especially if this patient comes in for a trauma or they come in for an emergency and we're treating them with narcotics. We can kind of mask that withdrawal until we start weaning them off. So signs and symptoms, so we can see them over here. Tremors, a little bit of anxiety, a headache, they'll be sweaty, some palpitations maybe, GI upset, but they have a normal mental status. Then we can have our seizures in patients. They can have hallucinations, visual, auditory, or tactile. They might still be oriented, but they're not able to do like basic like high function tasks. So I always have patients subtract 7 from 100 and then do it again. And if they're not able to do it again, then I'm like, okay, so they might know what day it is, but their brain is not functioning appropriately just yet. And then our DTs are delirium tremens is what DT stands for. So this is delirium, right? So they're going to be super confused, sudden onset confusion, agitation, tachycardia, hypertension, they'll have a fever, they'll be super sweaty, and we're at a really high risk of those seizures and that coma. So here's our DTs. These patients, again, so not able to pay attention very well, right? Might have to ask them a question a couple of times. They don't really know where they are, what's going on. They might have some slurred speech, mumbled, grumbled speech. We can see an autonomic hyperactivity, which results in cardiac collapse. So they might be super tachycardic and hypertensive until they're not able to maintain that anymore. And then we'll see a very big hypotension. Usually within 3 days of their last alcohol consumption. For the most part, if we are 72 hours post their last drink, we're in the clear. For the most part, right? Depends again on your patient. Generally, just 72 hours, and then they shouldn't be withdrawing anymore. But it can begin within 8 hours of their last drink. So they drank, went to bed, woke up, they can be DTs. Very high mortality rate. So again, these patients are going to be delirious, anxious, disoriented, having seizures, having hallucinations, tremors, tachycardia, hypertensive, all that good stuff. So when we assess our patients who are withdrawing, we do a CWA. So it's the Clinical Institute Withdrawal Assessment. It has like a rating scale, so it gives us like a numeric scale. So it gives us some objective data that we're then able to treat, and we treat it with benzos. So we treat it with Ativan is ideal. We can treat it with like diazepam if we have to. It tells us our risk and our severity of our withdrawal. We do 10 symptoms on a score of 0 to 67. If they are 67, we are not doing great. Okay, the higher the score, the worse our withdrawal is, the higher risk of morbidity for these patients. And so here's a CWA. It's really hard to see, but we assess for nausea, vomiting, right, on a scale of 1 to 7. Tremor, again, on a scale of 1 to 7, or 0 to 7. We're going to assess how sweaty they are, paroxysmal sweats, 0 to 7. Anxiety, 0 to 7. Agitation, 0 to 7. And then any hallucinations, so auditory, visual, those are 0 to 7. They have a headache, and then their orientation. And so some, depends on your nursing practice, I just ask them the questions, I can tell if they're nauseous or vomiting, right? I can tell that in my assessment. If I've been having to give them Zofran pretty frequently, I can score them on that. I can assess for a tremor. I can assess how sweaty they are. I ask them, like, how anxious are you? Is there anything that could help that anxiety? What's causing your anxiety? And I can kind of give you like a scale of like 0 to 7. Or I just ask them, 0 to 7, how anxious are you? You can assess how agitated they are. And then I ask them if they're seeing, hearing, feeling things that aren't there. Ask them if they have a headache. Okay, and then I do my, do you know what day it is? And then if they do, then can you subtract 7 from 100? And then subtract 7 again. Patients get pretty good sometimes at knowing how to answer these questions. At the same time, they're still withdrawing. They still have a high mortality rate. I'm going to treat them appropriately because undertreating them can cause them to have problems. I went to a rapid response once for a patient who the nurse was convinced was drug seeking. So she was undertreating his detoxing, and at about 3 in the morning he had a seizure and was intubated and brought to the ICU because he'd been being undertreated all night because we thought he was drug seeking when really he was probably at like that 16 range and needed the extra medications. And then we'll talk real quick mostly about like pancreatitis. So our pancreas has our exocrine and our endocrine capability. So endocrine is going to be like our glucose, insulin levels. Exocrine is going to be digestion. All right, so digestion of carbs, proteins, and fats. Where we get problems in pancreatitis is there's something causing some sort of inflammation of the pancreas, which is going to cause those enzymes to be released outside of the ducts and into the actual pancreas themselves. And these enzymes are used to break down our food, right? They break down what we eat. And so they're going to break down our pancreas because our pancreas is made out of fats, proteins, all that good stuff. And then if we have a release of these enzymes into our bloodstream, then they're also going to break down everything our bloodstream goes to. So we can have pancreatic enzymes breaking down our lung tissue, breaking down our cardiac tissue, breaking down our muscle tissue. So we can have acute or chronic. Chronic is often undetected because they have pretty like mild symptoms. But by the time we figure out what's going on with these patients, they can have a very significant loss of their endocrine function, right? It can result in like a type 2 or even like a type 1 diabetes, right? If we have absence of beta cells function. And then acute is emergent, right? This is a high risk of mortality and morbidity because we have these enzymes breaking down our healthy, normal body tissues. So again, activation of these pancreatic enzymes. Here we're going to have edema of our pancreas. We can also have a necrotizing pancreatitis. So this is like a severe pancreatitis. Okay, necrotizing pancreatitis, we can see severe abdominal pain. They might have like a peritonitis. They might have like a rigid abdomen. This is a high risk for sepsis, hemorrhage, and just like multi-organ dysfunction syndrome, right? Because we're having a mass release of our pancreatic enzymes. Signs and symptoms: severe abdominal pain is worse after a meal, right? Because we eat, it's going to release more enzymes. These enzymes are also leaking around our pancreatic area. Peritonitis. If we have peritonitis, this is an ominous sign. This means we have some pretty significant pancreatitis. We'll have bruising around the umbilicus and around their flanks, so it looks like a belt of bruising. Also an ominous sign. Nausea, vomiting, fever. They might be jaundice if they have liver involvement. Maybe a little confused. We'll see hypotension. We can see an acute kidney injury because again we're breaking down our renal tissue, as well as this hypotension can cause a pre-renal acute kidney injury. Maybe respiratory distress from breaking down or eating of our lung tissue. Hyperglycemia, right? Because our pancreas is being eaten, so it's not going to be releasing any insulin. And then DIC, because these enzymes are going to be causing a bunch of like micro traumas. So our body's going to fix those traumas with little micro clots. We can run out of clotting factors and end up with DIC. Diagnostics, so if we see serum pancreatic enzymes, so we'll check an amylase and a lipase, those should only be in our GI tract. We should not see them in our blood. Elevated white count, right, hyperglycemia, hypocalcemia. We can see with an ultrasound, because we'll see inflammation of the pancreas, or in a CT. In management, these patients, pain management, right? These are your guys who are on a Dilaudid PCA, a fentanyl PCA, a morphine PCA, right? This is very painful. They're going to be on bowel rest, so absolutely nothing, not even ice chips, right? If we put anything in our mouth, it's going to tell our brain we're eating, which is going to activate the release of those enzymes. They'll be on acid suppressants like H2 agonists, like our Pepsid, or a proton pump inhibitor. This should say parental feedings, not enteral feedings. Sorry. Parental feedings. So we don't want anything in the gut. Parental feedings. So like our TPN, just gonna put TPN. Or our PPN. Okay, we can give them nutrition that way. We don't want our gut having to do any of it. Strict fluid and electrolyte balances, and then we're gonna have to give them some insulin as well. Alright, if you guys have any questions, let me know. Thank you.